Hi guys, welcome to my YouTube channel. I am Aranas, a postgraduate medical intern. I basically provide informative videos to medical students, and also I would like to give aspiring Filipino physicians an idea of what a med student usually tackle in med school. If you find these videos helpful, please don't forget to hit the like button and subscribe to my channel and click the notification bell to be updated for my new videos that I'll be uploading every week. For today, I'll be discussing the clinicopathologic correlation of gastroesophageal reflux disease. This is a condition in which the acidified liquid content of the stomach goes back up to the esophagus. This is primarily due to the uh, impaired function of the lower esophageal sphincter. This is a very common outpatient department case, and it is usually mistaken for heart disease because of the most common complaint of chest pain. I would like to shout out to Zenra Tangliben for helping me out in creating this CPC. I'll be discussing each of these sections one by one. So let's start. Here are the important risk factors that we have to consider for GERD. First is the chronic use of medications, the advanced age of the patient, comorbidities like obesity, and a risk factor that is very important is cigarette smoking. So as for chronic use of medications, this is related to irritation and inflammation of the lining of esophagus. This would now exacerbate the uh, the damage that is caused by the reflux or the acid that goes back up into the esophagus. And the age of the patient would be related to decreased salivation and impaired esophageal clearance. Also, the elderly has a decreased barrier, predisposing them to uh, more damage from the reflux of the acid. As for obesity, it is related to alterations in adiponectin and leptin secretion, and also the increased gastric capacity and gastric pressure. Also, it is related to esophageal motor disorders. And according to recent studies, the obesity is related to hiatal hernia that predisposes to the development of GERD. And these motor disorders lead to diminished lower esophageal sphincter pressure. The cigarette smoking further uh, reduces the pressure of the lower esophageal sphincter because of the impairment that is caused by smoking cigarette. And also, it exacerbates the decreased salivation and would prolong the acid clearance in the esophagus, and also it would increase acid production. All of this would lead to the obesity, and cigarette smoking would lead to strain-induced reflux. And that would ultimately lead to the development of gastroesophageal reflux disease. This is classically manifested as a burning epigastric pain, or for the layman term, the heartburn. The persistence of the gastroesophageal reflux would lead to compensatory metaplasia of the esophagus, and that is the condition of Barrett's esophagus. This is commonly manifested as frequent heartburn more than 2 times a week and dysphagia, trouble swallowing. And also, at a severe end, it could manifest with signs and symptoms of bleeding, like vomiting blood or passing out melena. And when the um, Barrett's esophagus would be left unabated, it would lead to dysplasia, and finally to the development of esophageal adenocarcinoma. So GERD is a very important pre-malignant lesion, as it could lead to Barrett's esophagus and finally to the cancer of the esophagus. and this would be manifested commonly with weight loss and also anemia. Here is the reference of my discussion, the 20th edition, Harrison's Principles of Internal Medicine. I would like to leave you with this message. All of my flaws and imperfections are part of me, and I learned to love it. Thank you for listening and have a good day.